Hello everyone, let us begin with our topic rheumatoid arthritis. We'll study in this video about the etiology, pathogenesis, clinical features, investigations, deformity, stages of rheumatoid arthritis, treatment of the stages, and the classification on what the rheumatoid arthritis is based, and the prognosis and even the associated arthritis with other systems. So first we will see the definition and etiology. See, the definition of rheumatoid arthritis is nothing but it is chronic non-suppurative inflammation of the synovial joint. It is autoimmune inflammatory disorder. Now we'll see the etiology. Etiology of rheumatoid arthritis. It can be genetic and the general features. First we'll see the genetic. HLA factors, that is HLA-DR-P1 4 if 5 times more risk than normal person. Non-HLA factor, this is PADI4, this is peptidyl arginine deaminase 4. It is nothing but is a post-translation modification of arginine to citrullinine, means like it will arginine to citrullinine. If this gets affected, then the deposition of citrulline occur, and we'll study this further in pathogenesis of rheumatoid arthritis. The environmental factors which are harmful are smoking and the pollution or industrial factors, the silica present, and the protective factors might be the alcohol and OCPs. The general factor for this is it occurs more in female and which is 3:1 ratio, age 40 to 60 years, older age mostly, and in pregnancy also it has high chances of occurring because of increase in interleukin 10. And also in infections such as polymorphomonas gingivitis. Now the next study about the pathology of this. Okay, the pathology of this is genetic, and as we saw before, the genetic and the environment factors. These will cause abnormal protein modification. The abnormal protein modification will be detected as antigen by the APC cells, and the presence on T cells, the release of T helper cells to Th17 and Th1. The Th17 and Th1 will cause macrophage activation. This will cause TNF factor, tumor necrosis factor alpha activation, and then osteoporosis, and then weakening of bone. The T cell also causes release of inflammatory cells as neutrophils, and it causes, as you can see here, the synovium is discharged. You can see here this is the healthy synovium, and you can see here the irregular margins and all. This is synovium, hypertrophic synovium. This is hypertrophic synovium. This is the peripheral edges. Pannus is nothing but the abnormal proliferation of the synovium at the periphery. The most important feature of rheumatoid arthritis is periarticular osteopenia or erosion, and next it causes subluxation, that is, which is dislocation of joint. The clinical features are morning stiffness, which will occur for more than 30 minutes, swelling of 3 or more joint, which is known as synovitis of the joint, inflammation of the joint, and you have to remember one thing here, which is bilateral. It is unsymmetrical. If your index finger is affected, then of right hand, then index finger of left hand will also get affected. Rheumatoid nodule will be present, and rheumatoid factor may be positive. The rheumatoid arthritis will involve only the small joints. It involves only the small joints. It does not involve the large. It might involve, but rarely. The most common joints involved are metacarpopharyngeal joint, proximal interpharyngeal joint, and ulnar head in the hand. The distal interpharyngeal joint is paid. Yeah, as you can see here, these are the metacarpopharyngeal joint, and these are the proximal interpharyngeal joint. Now comes the investigation. Investigation is based on first, mainly you can see this is the most specific anti-CCP antibody, rheumatoid factor, acute phase reactant, that is ESR and CRP will increase. And in X-ray, the most specific finding in the X-ray will be Osteoporosis. As we have seen in pathogenesis also, osteoporosis occurs. It will decrease bone density and cause hyperemia. You have seen here the X-ray in the normal one is little darker, but you cannot see here because it is affected. Narrowing of joint space occurs in rheumatoid arthritis. Marginal erosions, as we have seen in case of PANS. There will be no sclerosis and no osteophytes. Sclerosis will be seen in osteoarthritis. Okay, now the deformity. Coming to the deformities of rheumatoid arthritis, here there are swan neck, proteiners, ulnar deviations, H-shaped thumb, trigger finger, hammer toe, and hallus valgus. Now we'll see this deformity in detail. First one is Bottomless deformity. It is due to the PIP joint is flexed and the DIP joint is extended. But opposite occurs in swan neck. How means like the PIP joint is extended and the DIP joint is flexed, which forms swan neck deformity, like swan's neck. Now coming to the ulnar deviation, as you can see the hand is shifted towards the ulnar border. And then Z-shaped deformity or zigzag deformity, the wrist joint will have flexion, the metacarpal joint will have hyperextension of the thumb, and the interphalangeal joints will have flexion. This causes zigzag shape of the thumb. Now coming to the trigger finger, it is mainly due to tenosynovitis. As you're seeing, the tendon is swollen here. It causes extension of the the trigger finger is mainly due to the tenosynovitis. As you're seeing here, in the normal it is not swollen, but in this case it is swollen, and it causes flexion of the DIP and the PIP joint. Now coming to the hallus valgus, it causes inward lifting of the great toe, due to which the toes appear like bent pattern. Due to the inward lifting of the great toe, these fingers will be in bent form, which is known as hammer toe. It forms hammer toe later. The great toe is the hallus valgus, but this bent position is hammer toe. There is potentially reversible stage which will only cause hypertrophy of the synovium, but there will be no changes on X-ray. This treatment will be by DMRDS, NSAIDs, and synovectomy plus joint mobilization. Controllable but irreversible. It is like here the X-ray will be, in X-ray they will show decreased joint space, cartilage erosion will be present, but the outline of articular surface will be maintained. This can also be treated by NSAIDs and DMRDAs. DMRDAs is nothing but it can be treated by NSAIDs and DMARDS. And also the soft tissue repair, arthroplasty and splints are required for controllable but irreversible form. Reversible, the PANS is destroyed, complete destruction of joint, ankylosed joint, dislocated joint are the features of irreversible later stages. Here NSAID, splint, arthroplasty, orthodesis, walking aids are all required. Now we'll go to proper definite treatment of the rheumatoid arthritis. It contains steroids, DMARDS, and the DMARDS action starts by 6 to 8 weeks, it is 1.5 months. The first line drug is methotrexate. The dose is between 5 to 20 milligrams weekly for 3 months. The side effects for methotrexate is mucositis, ulcer, hair loss, hepatotoxic. It is hepatotoxic, bone marrow suppression and all. After 3 months, either the readmission, they'll check for the symptoms and signs. If more than one joint is involved, if the joints are still swollen, and the global assessment is more than one, based on that, there will be adequate response and non-adequate response. If adequate response, then the methotrexate will be continued. If non-adequate response, if the response is non-adequate, then methotrexate, sulfasaline, and hydrochloroquine. Methotrexate plus anti-tumor necrosis factor alpha will be given. Methotrexate or JAK inhibitor. These are mostly used because these are easily available and less costly. This JAK inhibitor. Now we'll come to the ELR classifications. ELR classifications of rheumatoid arthritis. Here we can see the scoring system is based. As you can see, if the score is more than 6, then there will be definite arthritis. The scoring depends on type of joint involvement, serologic test, acute phase reactants, and duration of the symptoms. You can see here the large joint is only one. If one large joint involves, and his grading is score is 0. 2. As we have known that rheumatoid arthritis will involve mostly small joints. 4 to 10 small joints, and the grade is score is 3. More than 10 joints, more than 10 small joints, then the score is 5. Serology, negative rheumatic factor, negative uh, anti-citrulline protein antibody is negative. Both rheumatic factor and anti-ECP antibody is negative and 0. If low positive ECP, the grade is 2. High positive and both are present, then the grade is 3. Acute phase reactant. If the CRP and the ESR are normal, then the grade is 0. If abnormal CRP and abnormal ESR, then 1. Duration of symptom less than 6 weeks, the grade is 0. More than 6 weeks, the grade is 1. Based on these features, we score and treat for the rheumatoid arthritis. Coming for prognosis. Prognosis is worst in anemia if rheumatoid factor is present and old age. The associated features we'll see in the next video clearly about which all systems are affected and what all. But for now, you have to remember the simple points, that is scleritis, carditis, pleuritis, lung, heart, eyes are involved in rheumatoid arthritis. The Kaplan syndrome, which is rheumatoid arthritis plus pneumoconiosis, a lung disease. Felty syndrome, which is neutropenia, rheumatoid arthritis, splenomegaly, it is hematology disease, blood disease. Thank you. Hope you like my video.